Hi, welcome to the Clinical Documentation Lecture Series. Today we'll be talking about the top underdocumented diagnoses in Emory Healthcare. This is our team of CDI medical directors. My name is Yumi Shin. I'm the medical director of CDI at Emory Midtown Hospital. We have Dr. Jessica Nave Allen over at EUH. We have Dr. Jason Velasquez over at St. Joe's. We have Dr. Ingrid Pinzon over at Johns Creek, and we have Dr. Matthew Hogan at Emory Decatur. The first question that providers have about clinical documentation is, why does it matter to me? Everything we write in the patient's chart will be used for several purposes, and some of these purposes directly affect us as providers. Those include length of stay, quality metrics, so what you write will translate directly into how well others think you're taking care of the patient. For example, insurance companies and quality reporting avenues. It can also become a measure of comparison, so how am I doing in relation to my peers? And also it will add to show how my hospital is doing in relation to other hospitals similar to mine. It directly affects our reimbursement rates, our coding and billing data, and it also goes to show medical necessity for our patients and also goes to add to denials from insurance companies for the patient's care. As the provider, we need to document the diagnosis into our notes, and according to CMS guidelines, we cannot use nursing, wound care, registered dietitians, ENT notes to obtain critical diagnoses. Every patient is categorized into a diagnosis-related group known as a DRG. Each DRG has a length of stay associated with it. Adding a CC, a complication or comorbidity, or an MCC, a major complication or comorbidity, will get you to the highest DRG, which will then maximize the risk of mortality, severity of illness, the length of stay, and the reimbursement. If you think of DRGs as a triangle, you can see the base DRG without any CCs or MCCs will have the lowest reimbursement, ROM, SOI, and also length of stay. As you add CCs and MCCs to the patient's diagnoses, it would increase the reimbursement, the ROM, SOI, and length of stay. This is why it is important for us to capture and document all of the CCs and MCCs that the patient has.
Malnutrition can be acute, subacute, or chronic, and this depends on the degree of overnutrition or undernutrition in our patients. We know this is a difficult diagnosis for our physicians, and we rely on our registered dietitian for the diagnosis. There are 3 degrees of malnutrition: mild, that would add a complication comorbidity to these patients; moderate, that would add a complication comorbidity to; and severe, and this would add a major complication comorbidity. Remember that this will help with our length of stays and reimbursement. Please do not forget to agree with our dietitian's diagnosis and sign their notes.
Congestive heart failure is a condition where you have inadequate cardiac output resulting from functional or structural abnormalities of the heart. When documenting heart failure, it's important to document the acuity of heart failure and also the type of heart failure. For acuity, you can either document acute or chronic heart failure or acute on chronic heart failure. For the type of heart failure, you can document systolic or diastolic heart failure, or you can also use the terms reduced EF or preserved EF. Acute systolic and acute diastolic heart failure can add an MCC to the chart, and chronic systolic heart failure or chronic diastolic heart failure can add a CC to the chart.
Electrolyte abnormalities are also important to document as they impact quality and mortality calculations, especially in our postoperative patients. For example, hypo or hypernatremia is a CC, which is a complication and comorbidity, and puts us into a higher DRG within that base DRG cluster for any primary diagnosis. We need to make sure that we use the actual coding terminology, so hypo or hypernatremia, kalemia, magnesemia, etc. We can't say elevated sodium or low potassium. We actually have to use the correct terminology. Metabolic acidosis and alkalosis also count as a CC, so are very important to capture. Electrolyte abnormalities are some of the most commonly queried diagnoses that you'll receive from our CDI specialists.
Acute blood loss anemia is an absolute reduction in the number of circulating red blood cells that occurs in an acute time frame. This can be documented as a reduction in hemoglobin, hematocrit, or total red blood cell count. To qualify for acute blood loss anemia, the hemoglobin must drop 1 to 2 points and/or the hematocrit must drop 3 to 6%. Other supporting criteria include whether a transfusion was given or whether a patient had symptoms such as shortness of breath, chest pain, or weakness, along with the anemia. Appropriate terms to document could also include anemia due to acute blood loss, acute hemorrhagic anemia, acute post-hemorrhagic anemia, or anemia due to postoperative blood loss. Please note that acute blood loss anemia is a complicating and comorbid condition.
Hypertensive crisis is the sudden increase in blood pressure over hours to days, with your blood pressure being more than 180 over 120. Some old terms that are still being used are accelerated hypertension or malignant hypertension, and I would stay away from these old terms and instead try to use the words hypertensive urgency, that indicates no end organ damage with high blood pressure, or hypertensive emergency, where patients do have end organ damage and are generally in the ICU. Hypertensive emergency will add a CC to the chart. Thank you so much for listening. Please feel free to email us with any questions.